Thank you so much, everybody, for being here. For those of you who don't know me, I am Elaine Anderson, and I mention that in the context of a role that I have here in the School of Public Health as the advanced professor. And for those of you who do not know much about the advanced program at the University of Maryland, this is an initiative across all schools and colleges here at the university to address the challenges that sometimes we face in helping women in particular, but also other underrepresented groups to not only come into the university system, but to succeed and to then advance. And so this particular session is the School of Public Health's Advance initiative in terms of our large seminar for the year. And it's really in that context that we are thrilled that Dr. Karen DeSalvo has joined us. I also want to thank any of our colleagues who are here from the School of Public Policy, who are also doing some partnering work with us this year, as Boris would say, as part of the publics. Here at the university. So we're going to do this a little bit differently and introduce, you are going to learn about Karen and her work in a little bit different way than typically we do with our introductions. So you're not going to initially hear the list of the multiple things that she has done and has achieved, but you're going to learn more about that through the format we're going to use this afternoon. I will just simply start by saying that Dr. DeSalvo does have her degree in medicine from Tulane University, and she also has a Master's of Public Health from Tulane, so she can think about numbers of our areas of work here, and she has a Master's in Epidemiology that she received from Harvard. So I think she's going to be able to bring a lot of areas of expertise to us that many of us can relate with. And having most recently exited out of her position as Acting Assistant Secretary of Health in the U.S. Department of Health and Human Services, you are going to hear a lot more about her work with that as well. But I thought that it might be important and help all of us to learn a little bit more about Karen and the contextual piece, as we say in family science here about Karen. So I've asked Boris, our Dean Luchniak, to give us just a brief, and you all understand why I'm saying that, explanation, a statement about his relationship with Karen.
Thank you, Elaine, and thank you again to Karen DeSalvo for agreeing to be our advanced lecturer today, and thank you to the participants here throughout various facets of the day. I think we've already shown Dr. DeSalvo the beauty of our school in terms of both its diversity. She spent a little time with our undergrads today. She spent some time with faculty members. She went out to breakfast with a few of us earlier today. And now at this sort of lecture interview format, we'll learn a little bit more about her. But I'm not here to tell you about her CV by any means. We'll get a sense of that because she is quite the accomplished person. We heard a little bit about it already. I want to give you that story of how I first met her, right? In a whole different life, in a whole different world that used to exist out there, which was our lives in government service. And first and foremost, there is a person here amongst us, right, who has experienced that sense of service, much like many of you have done service to the academic world, to our students, to perhaps government agencies. Karen is one that has served at the local level down in New Orleans. We'll hear a little bit about the crises and the challenges and the beauty of that work of service. But I met her at government service at the federal level. And I actually remember the day I first met you. And it was a day where all of a sudden we had this brand new national coordinator for health IT coming in. This was an outside person in this world of a mix. And the mix was mostly political appointee sitting in the room with the Secretary of Health and Human Services in the big rectangle. I was a career officer serving as the acting Surgeon General of the United States, and she sat down next to me, I remember, and was kind to me. And I thought, you must be new here, because most of the politicals, frankly, weren't that kind. There always was a separation. And I thought, wow, this person, you know, is nice. And that's part of the concept, is you can do incredible things. You can advance into incredible titles and be focused on a mission. And at the same time, you can actually be nice. So that's my biggest compliment to a person like Karen DeSalvo. We then had crises, of course, presented in front of us. And the pictures I was going to show, which are on my slide set, but unfortunately the Apple didn't talk with the Mac, or the Mac didn't talk with the Windows. The windows were closed to the Mac, perhaps is the metaphor that I will use, were the times that we spent with Ebola. Because that was the time where she was put into the position. We had two actings working together. She was the acting Assistant Secretary for Health, at the same time still carrying her national coordinator hat, which was an incredible juggle to go through. I was the acting Surgeon General, and we had Ebola ahead of us. And therein, in the time of crisis, right, is where we see leadership shine. Right? This were not easy times. This was scary for our nation, scary for the population of our nation, scary for the world. And yet what I saw of Karen DeSalvo at that moment was a decisive person who can take on leadership roles. She was there when we had made decisions about sending our officers of the U.S. Public Health Service. And you know, her token today, which is very important to me as a former officer, is she's wearing a lapel pin that crosses the flags of the United States with that of the Commissioned Corps of the United States Public Health Service. She was one of us, never in uniform, but one of us. We made decisions. We acted upon those decisions. I still remember when we went down to Atlanta and we welcomed back the first team that returned, the first team of Health and Human Services, Commissioned Corps officers who returned from their 3-month deployment to Liberia. And she was there next to me hugging people who were coming off the plane dismayed. Right? This is before Christmas, 2014. They hadn't been touched in 90 days. No one hugged them. And yet we were there. An emotional component of seeing the pride and the joy of a leader, extending that to others. Months later, when I was given the honor to command that same hospital, Karen came to visit us in Liberia. Right? And the images I was going to show you, the word that I had, you know, the lectures that I've given about this, if you remember the lifeguard's nest, which I've talked about openly, the picture is of one of her and me sitting on that same lifeguard chair at the Monrovia Medical Unit. And one picture that I was going down, so this is a visual. We're on this lifeguard chair at this military base run by the Public Health Service where Ebola patients are both dying as well as getting cured. She came to visit the troops as the acting Assistant Secretary for Health. She gave them that rah-rah. She gave them that love, a word we don't use oftentimes in public health. She gave them that embrace, although at that time it was just a metaphorical embrace. But the two pictures I was going to show is her and I, she and I, sitting side by side. And in one of them, I'm pointing out something to her. But then in the other one, she's pointing out something to me, probably correcting me. So without further ado, a compassionate soul, an incredible leader, a role model for all. Ladies and gentlemen, Dr. Karen DeSalvo.
Thank you. You should just stop there. Well, Boris, thank you. First of all, Elaine, thank you for the day so far. It's been really tremendous. I've had a chance to meet a lot of really great folks here at the University of Maryland, and I was really happy when Boris invited me. Boris is right. We went through some stuff together, and it's worthy of an entire talk. But he skates over several months of intensity in which his leadership carried the Commissioned Corps into the field to do something that they'd never done before, and we brought home every single officer safe and saved a lot of lives. I'll be proud of that forever. What I'm going to try to do in 10 minutes is tell you a little bit about myself, and then we're going to have lots of time for questions. So we'll have some structured questions, and I hope you all will chime in, especially students and others that are interested in what steps they might take in their career. So I was raised by a single parent. My dad left when I was 5, and my mom took it upon herself to make sure that we knew we were loved unconditionally, and that education would be our way out of poverty, and got us pretty focused on thinking about how we would be able to support ourselves going forward. So from a very young age, I felt quite supported, but we also had pretty limited resources. I made a decision early in life that I wanted to be a doctor. It was a very structured decision where I was going to be a dancer, and I decided that there were reasons that was not going to pan out for me, but that I wanted to go into medicine, and I was going to be the first in my family to go into medicine. My mom hadn't yet graduated from college, nor my dad, so it was a sort of a big idea for a little girl who had this idea that you could blend science and helping people, and that it would be a good way to spend your life. Through some fits and starts, not all smooth sailing, I was able to get myself through college, graduate, get into medical school at Tulane, the place I wanted to go because I fell in love with the building in the background of this picture, Charity Hospital. My parents had grown up in New Orleans, and my family had a lot of personal ties to this building. My grandfather had died there. My uncle had been a social worker there. My aunt had done her nursing training there. And like many people in our community, we were tied there professionally or personally because of sickness. It's a building that has taken care of people for about as long as the Public Health Service Commission Corps has, honestly, since the late 1700s. And it was the way that we thought about health, frankly, in New Orleans, which is where I was in med school. We really thought that the answer to improving people's health was to have fancier machines and faster operating room times and more specialists, because that was the solution to creating health. But we were also spending, I think, a lot of time learning on people who were pretty sick by the time they walked through our doors. And the experience of healthcare in New Orleans, certainly when I was in med school, and then up until the time that Hurricane Katrina hit in 2005, was one that was really focused on hospitals, specialists, doctors, and really a thinking about patching people up instead of trying to prevent illness. Even though public health has a long track record in New Orleans, it was long forgotten by the time I got there, and it was pretty marginalized in the world of health and healthcare. I was on the faculty at Tulane, having done National Health Service Corps to pay for medical school, served my time at Charity Hospital, and was taking on some administrative and leadership roles there. I ran the resident clinic. I ran that only because the chairman of medicine told me that starting July 1st, I was going to be the director of the resident clinic, and I said, that's really nice, but I don't like outpatient medicine. I'm an inpatient doctor. And he said, that's really nice. Starting July 1, you're going to be running the outpatient clinic. And that's the way we used to do things, right? And it was one of the best things that ever happened, because it forced me into a world that I thought was dysfunctional and broken, and caused me to have to think about how to fix and improve it. I got really involved in quality improvement and in systems-based thinking at the healthcare level. My first dabbling in electronic health records and data systems to improve care, and had the chance to not only see all my own patients in my clinic, my direct patients, but run the resident clinic. So I saw, you're going to think I'm crazy when I say this, but thousands of patients a month that would come through the doors, because we would see patients in the resident clinic, and I would see them on my own, and I would see them on the wards, and I got to begin to really understand the barriers to wellness for the people that we care for, people that we wanted to help, and they were not having, their diabetes was not controlled because they didn't understand that they shouldn't eat sugary foods or starchy foods, but because they were more preoccupied with getting through the day. They had financial stressors and emotional stressors, and there were reasons that were preventing their wellness. They began to teach me that over the course of time. I started to do research. I had the chance to become a Robert Wood Johnson General's Faculty Scholar. Got some funding to be able to take this idea of systems-based practice and apply it in a more rigorous way, and build a scientific portfolio that took into account patients' sense of self, how they reported their self-rated health, and how that could predict their outcomes, and how we could build health systems that would be more designed for them, particularly to treat chronic disease, and thinking about it in the safety net infrastructure. As part of that period of my career, I was doing a lot of administrative work at the university. I was the chief of general medicine, which is a line job, right? So I had faculty reporting to me. We worked in the VA, at the public hospital, at the academic medical center. I was doing my research. I was teaching, seeing patients. But the truth is that somewhere around May of 2005, I was quietly packing up my med school office and moving everything down the street to my School of Public Health office with the intention that come that July 1, I would no longer be the chief of general medicine and be primarily based in the School of Public Health, because what my patients had been teaching me for years, what the data was telling me, was that health was about more than healthcare, and that I might be able to do more through the House of Public Health than the House of Medicine. But Hurricane Katrina had other plans for me, like she did for so many people. And in the summer of 2005, in August, there are reasons that I stayed, and it has to do with a chair stepping down. That's too long of a story, I don't care, but I stayed as a favor to the interim chair and found myself still in the seat of academia and medicine at the time of Katrina. And everything changed for everyone in the community. It was a catastrophe, and I say that with a clear mind and heart that we are in the midst of many catastrophes in this country right now. This was our story about flooding when the levees broke and our city was underwater for 30 days. We were under mandatory evacuation, and so not only did the infrastructure flood and rot because it stayed wet for so long, but we were all cast to the diaspora. People's families were disrupted, and we were pretty cavalier about it. I happened to be camping in Alaska at the time of the storm, so my experience is slightly different, but nearly everyone you asked from New Orleans or the Gulf Coast of Mississippi would tell you they packed up for their hurricane to go away for a few days, or they stayed in place thinking that it was going to blow over like everything else had, or be like a Betsy that flooded a little bit and went away. And that was not what Katrina did. She changed the trajectory of our city and many of our lives forever. And so I start with this picture because if I were a person who would get tattoos, and I'm not, I would have a tattoo of a hurricane on my body because she changed the way I saw the world, thought about the world, and how I want to spend the rest of my career and have so far. Charity Hospital, which had been the attractant for me and so many people who trained in medicine, flooded, not in the way that many of us might think, but the basement filled with water, the basement where we kept medical records, dietary, the morgue. But it destroyed all the electrical and infrastructure, and whether we debated for years whether she should be closed, but she was. The state was not going to reopen this hospital in spite of protestations, and so there was a need to really not only think about the safety net hospital, but it created, quite frankly, an opportunity, a vacuum for us to really think about how to create a new health system. Very early, so the storm was August 31st, August 29, 2005, excuse me, and then somewhere, I got back to New Orleans around the middle of September and had our first community meeting on the ramp at Charity Hospital. Water by then had receded in this part of town, and some of us had come back to think about how we could help the people in the community that we knew were still there or who were going to soon return. I told some of the undergrads this morning that I had actually had a call from some of my residents, my trainees, saying that they wanted to reopen Charity Hospital and was I in. I mean, that's exactly how they said it to me, and I thought they had really lost their minds because they'd all been in the hospital during the storm and they had just left, and I knew they were tired, but they were dead serious. And so I met them on the ramp along with some other folks, and it was clear we were not going to reopen Charity, but that was the beginning of us thinking how to work together as a community to create the conditions in which everyone can be healthy. We looked at each other in that ramp and said, oh, you're from Catholic Charities? Oh, you're from Daughters of Charity? Oh, you're from this, from the School of Nursing? This is great. My name is Karen, and how can we figure out what to do together? And we built our wings after we jumped off the cliff is the easiest way to describe it. And though there's a structured kind of response in disaster today, It wasn't quite as structured back then, and though the commission core was all across the Gulf Coast, the people didn't really think to send people to the heart of New Orleans, quite frankly. And so there were a lot of us volunteers just sort of setting up card tables and ice chests to provide care for people on the street. That dotted landscape of ice chests and card tables and breaking into buildings, yes we did, that were high and dry to take them over so we could store supplies overnight and not have to bring them back and forth, became over the course of time not just a place that we provided urgent care, but over the course of months and then years. And then I'm going to try to do this, but I've got it backwards. No. Became a network of community-based clinics. And this wasn't just an accident. I think that maybe the key thing I wanted to say here, and I was asked it this morning, is this moment in time, I found myself having to make a choice about staying in the ivory tower of academics or using what I knew from the ivory tower and the relationships that I had with patients, with national folks, with new relationships and community, to rebuild a community and to give back something to New Orleans that was not the same system we had, but something that was deserving of the people of New Orleans. Why would we want to do that? We had the highest cost, worst health outcomes in the country. And if you rebuild a system exactly the way that you had it, then you're going to end up with the highest cost, worst health outcomes in the country. And we very deliberately, very early said, we need to do different. We need to move upstream. We need to have more primary care in neighborhoods. We've already got some beachheads because we're standing out on the street taking care of patients. Let's see if this is the right kind of place to build for the future. We built a policy framework around it where we found a way to fund it, enable it with health IT, and eventually do coverage expansion, which wasn't complete until Medicaid expansion just a little over a year ago, which is remarkable to think about. It took 12 years. This work required me to ask forgiveness to take a break from my grants, ask permission from the university president to take a break from my usual administrative duties, but was well worth it because I think over the course of time what we've built is an infrastructure that's financially solid and taking care of about 200,000 people across the community. And I hope we get to talk about it a little bit more. It's been a journey of 1,000 people to see this happen. But I reached a point on this part of my journey where even though we'd gone upstream to deliver more primary care, it seemed that we were running into the fact that people left our clinics and lived in communities that were unhealthy, and that there was going to be an awful lot more that we were going to need to do to bring health and just redesign the healthcare system. Oops, go backwards. Which pushed and pulled me to stepping out of the House of Medicine, out of the thinking of health care as a way to improve health and to becoming the health commissioner. It was, I naively thought I was going to pop over there to City Hall and be health commissioner for a year, fix up the health department so it could help the city and go back to my usual life in academics. And I'm not embarrassed or ashamed at how arrogant I was because it's just part of how you grow up. But I look back at that woman who did that and who thought that in 2010 and just can't believe that I didn't understand how beautiful the practice of public health was and how important it is and how complicated it is. It was 3 years of a wonderful experience. One of the favorite things I've ever gotten to do is be the doctor for a whole city, to really help build a future public health department based upon accreditation, and do that with a tremendous team and get to interact with the community, not just giving kids high fives at the finish line, but really talking to kids about what their future should look like and helping shape that for them in ways that are structural, and we're starting to really see improvements. This is a city, New Orleans, that chose to go smoke-free a few years ago, which may surprise many of you, but that's the kind of cultural shift that we have had, and I think the health department had some hand in doing some of that. I was very happy doing my thing, but I got a call from Kathleen Sebelius. She's very sneaky. She called me on a Saturday on like a different line, and I didn't know who it was, and said, don't say no, just think about it. She wanted me to be the national coordinator for health IT, and I'm not a technologist. turns out I knew more than I thought I knew. Turns out it was a really great experience, but the attractant, in addition to seeing that technology and data could be used not just to improve healthcare, but improve health. This was her one selling point to me. Like, let's think about how it's going to help public health, but it was also, do you want to think about how we can change the way we're paying for care to drive it towards a health system and not a healthcare system, move to value-based payment, outcomes-based payment. I show off by showing this picture because I had a lot of great moments in service and government, but I had one very surprising morning when I got a call from then Secretary Burwell's staff saying, hey, are you in town? Because the secretary's going over to see the president to tell him about delivery system reform, and she wants you and Patrick Conway to join her. So thank goodness I didn't find out till like an hour before. I didn't even have time to worry about it or figure out what I was going to wear. We just got in the car and went over to the White House, to the Oval Office, and got to pitch delivery system reform to the president and have him say my name and ask me a question, which I apparently was able to answer. And I don't remember very much about it, but it was, he said yes. And Joe Biden, by the way, sitting right here, which was also nerve-wracking. And had a really good thing going, doing technology and improving the healthcare system to try to make it at least more inclusive of public health. And then, as Boris said, I got asked to pick up a third job, I guess, is what it was. And that was back in really more of my sweet spot around public health, so it was an easy yes. That allowed me to blend technology and the language of healthcare and start to build some bridges between what healthcare and public health and technology could and should do together to advance health, to create a more modern infrastructure. We did some very deep public health things, a lot of work with the Commission Corps. This is a day that we had just come out of the Oval Office, and there you are, Boris, right to my left. The officers got a medal for their service in Ebola. But that's one of the many heroic things they do. They're doing that every day. Can you tell I'm a fan? But there's more to the public health work we did there. Dietary guidelines, Healthy People 2020, vaccine program, blood safety. A really interesting opportunity, I think, to work at the federal level, thinking of how we can drive policy and what are the priorities for the federal government. I had shared with a smaller group earlier, and it's probably worthy of me sharing now. I think that as much fun as this is, public health isn't yet the priority in health and human services that I would hope to see it be one day, or in any C-suite or boardroom, quite frankly, which is sort of brings me to what I've been up to today. I am probably on a self-styled sabbatical is the best way to describe it since I left government, and been doing a lot of thinking and working on trying to understand a few statistics. I'm going to go back to that in a second because well, maybe I won't. I think over the course of all this in my life, including being a kid who grew up in poverty and seeing the different trajectories that my life took versus my neighbors, really trying to think through why is it some people do well, why are some people healthy and some people not, why do some people have better quality of life and some people not. There are lots of statistics that stick in my head. This is just a couple of pieces that I would point to. You know, this is a map done by Virginia Commonwealth University by Steve Wolf that shows in my hometown of New Orleans the 25-year gap in life expectancy based upon whether you live in the housing development near the French Quarter, where some of y'all might have had beignets, and quite frankly, there's a 20-year gap just between where you might buy your beignet and where the people who are making your beignets live. Right behind the French Quarter. If you live up by the lake, you get an extra 5 years. This is not just a New Orleans issue, as you all know. This is all across our country, and there's a pretty dramatic difference in your life expectancy based upon where you live. And it's not just that you happen to live in a place that's not polluted, it's that you live in a community that's rich in resources, and including education and public safety, and that you have opportunities that maybe kids just a few blocks away don't have. This idea that there are non-medical determinants of health, just to go back to Katrina, was not academic to us anymore at the time of Katrina, because when you're on the street, in a neighborhood that was flooded and destroyed, and you're sitting across the card table from somebody whose flattened house is behind you, trying to talk to them about their diabetes, you become pretty aware that sort of talking to them about the best dosage for their insulin is kind of ridiculous when they don't actually have a house to live in or they don't have electricity. So it wasn't even academic for us, it was real. And I think but the exciting part is that now, between the big data science, small mapping science, I think this idea that the C-suites of America, boardrooms of hospitals, of corporate America, of payers, are beginning to understand that there's more to health than healthcare. What many in public health have known for generations, this is now becoming a mainstream idea that I hope we don't turn into a fad, but actually use as an opportunity to really change and leverage policy. And I'm just going to end with something that I might point you guys to. You won't be able to find it anymore on the website. Someone asked me about this earlier. They've taken this down off of the government's website, but because it was a really controversial report based on a set of listening sessions we did around the country, trying to understand how communities are learning to address the social determinants together. What does this new version of public health look like at the community level? How are they building multisectoral partnerships? There are sort of 5 key ingredients about using data and leadership and finding ways to commingle money and to really set goals together. There's wonderful examples about places like Nashville, led by people like Bill Frist, all the way to places like Erie, Pennsylvania, who was on NPR this morning for some of their work around opioids. But I can point you to a paper that we just wrote that talked about it, which is on the cdc.gov website, and I should have linked the reference. Well, I just want to end on this to say that my time as the acting ASH was rich in many ways, but it was one of the reasons because we got to put out this report about 3.0, which was a way that I could not only talk about the science of the social determinants, but how communities are solving it. I think for my message to you all as public health professionals and as aspiring leaders in public health, for those of you who are students, is that it is incumbent upon us to not only work within ourselves in public health to improve the public's health, but the world is really hungry for our expertise and for our understanding about how systems and policy and environmental level indicators can really make a difference, how we can use public health law and relationships at the community level to really make change. And there's some great models of how this is working, but this is just beginning. And we have a lot of field building and science to move forward on, but I think also a lot of culture change. But I'm excited about it, and hopefully we'll get to talk a little bit more about it. I went on way too long, so let's get up and get talking. Thank you, guys.
So I think you can see already why we were excited about Karen joining us. We've invited 2 former advanced professors, not advanced, maybe advanced too, but whatever. And Jane and Dushanka, who I know you all know, are going to engage in a conversation with Karen, and then we'll leave some time for us all to ask some questions too.
Well, I just want to say, first of all, thank you so much for giving us not only a very personal picture of your experience, but also a heartfelt one. We can see it, we can hear it, and we benefited from it. I think I have a PDF of the document, so if anybody wants it.
I need to make a shell website.
That's right, we can make sure. So,
is it on the Wayback website?
No, it's on from there now too. It's in, well, it might be. It's in, but you can find most of the results in preventing chronic disease.
That's right.
And we just published it. And this is the community's words, and also a lot of federal recommendations, recommendations that point to the federal government, to states, to the private sector about what could be done to make it easier for these communities to be successful.
So I know I have the question that Dushanka has pointed me to, but I want to follow up on something you said at lunch, which was this interaction between the federal government and the state and local governments. Mm-hmm. So I thought you had some good insights about our sort of always emphasizing what the federal government is doing, and at the current situation we have right now, how to think about the state and local. Could you kind of...
The leadership.
And how to think about this today as we go forward.
Right. Well, want to reflect about what the role of government is in health. And we actually had some additional conversation about this at breakfast. And a lot of what we do in the role of government is to protect individuals, but also balance that against the common good. And there's not really, I mean, honestly, I can't think of anyone besides governmental public health who has an accountability to everybody in the community for their health. It's a, you know, if you're a healthcare system, you just might think it's a nice thing to do for a little bit of time, but statutorily, public health has that responsibility. And as you get closer and closer to the ground, you know, local health officers are even more accountable because they have that proximity than up at the federal level. So if you just think about that as your responsibility, I think it's just a good reminder that though it feels fancy to work in the federal government, and it's great that there are other backstops to protecting the public's health besides just the federal government. And so if you want to make a difference, if you want to protect people from transmission of disease or from their own environment to help them advance, that you have to remember that there are backstops and layers. And you know, in times when maybe federal policy might not support, say, vaccines, as an example, there's a real opportunity for state and local government to make sure they step in and amplify their voices to help avoid vaccine hesitancy. And so there's some, you know, I think there's some real, not only opportunity for protection, but I think for doing good. Does that get to you?
Yeah, I think that's what I heard you say. But my question that I was supposed to ask is the one that intrigued me when I first opened your CV, and I saw that you majored and a co-major in political science.
Sure.
So for those of us who are either graduate students, maybe an undergraduate student here or there, what do you think about having a biology and a political science major? And obviously, this political science major must have played a big role in your life in terms of what is government.
I am such a generalist. Right? This is my whole problem. That's why I think why I love being health commissioner. I'm a general internist. You know, that's why I love the ASH job because it was very general. And so it's not surprising that I would have a double major, one in a science and one in a whatever political science. Here's why I did that. I did it partially out of intellectual curiosity, but also because I thought I was going to do international health, and particularly thought I was going to do work in Africa. And I felt like I needed to understand how government worked, since government, except for here, typically runs healthcare overseas. So it was very strategic. And then I went to Tulane to study. Anyway, I went to Tulane to study medicine and do a master's in public health and tropical medicine. Right. But after a semester, basically, I said, there's enough to do here. I don't need to go to Africa. I've got plenty of work in the U.S. and so I changed my Trop Med just to MPH. That's why I had that.
So sort of follow up on that. So you end up in policy a lot. So you know, I was a basic scientist person, and so when I got to the administrative positions, I went, gosh, I didn't know policy should be so important. So how did I miss not majoring in policy? What background, what kind of work did you do to get ready to do the policy work that you did?
Well, science, and I think that so science and practical experience make a big difference, and it was one of the reasons that I know Kathleen Sebelius asked me to come to Washington, because I had been, you know, I'd been a doctor, I had been working in the trenches, as they say, so I had a real understanding of different kinds of healthcare systems. I'd run them, but I'd also cared for patients and done some systems work, and I had an evidence-based background, so I was able to ask questions, do study design, look at results, and that I think that really helps. I got some great advice from a mentor, a guy named Hal Sox, who used to be the editor at Annals, who was my mentor in the Robert Wood Johnson Clinical Scholars Program, and he would always tell us, don't jump straight into policy, go do something practical, build your scientific foundation so that when you're making policy, you know how to look at the evidence. And the policy thing. So I'm a very resourceful person. I'm going to tell you a few things that you're not going to ask. But I'm very resourceful. I can build a lot of things with 2 nickels and some friends: a hospital, a clinic, a city, all kind of stuff. And so that and the reason I raise that in this context is because even if I didn't know how to do it, I was going to figure it out, right? So I'm going to go scrap around and find it. I'm not afraid to say I don't know, which is I've had to say a lot of times along my career. And I was really passionate, as you can tell, about all this. I felt like when I was sitting in the airport in Houston, making my way back to Louisiana, I was going through whatever. I was in the airport in Houston because there was no way to get directly to New Orleans, and the newspaper was about some legislator saying, some federal, congressperson saying that New Orleans ought to just shut down and say goodbye because it just floods and it's a bunch of useless people anyway. Does that sound familiar? Yeah. And
Just an island.
I started crying, and in that reading and the crying and the whatever was in the airport, I had an epigenetic phenomenon. I'm like, I'm going back and we're going to bring this city back and we're going to prove them wrong. It was like we were the three-legged dog, and they whacked us in the other leg, and then we're like trying to get up. But the way that we got up is we all looked around and said, we'll help each other up. And we all sort of figured out how to stand up together. And I realized, though, it wasn't going to be just about helping each other stand up, because people were going to, that's a temporary, relationships are temporary, policy is permanent. And so I needed to learn how to codify in policy. I needed to learn how we were going to become federally qualified health centers, and how we were going to expand coverage, and how we were going to define quality and what were the outcomes we were shooting for, and how we would do IT and pay for it. So you build a prototype, but you have to have a way to sustain it, and that's where policy really helps, just like smoking policy.
Well, I'm going to deviate from our prepared questions also.
I do that to people, by the way.
Well, it's your energy that sort of catalyzes us. But you opened the door with Public Health 3.0 and also with the social determinants of health, and actually identifying the fact that you've done things at all levels, but at that local level, I'm interested, where do you think is the most likely pathway to creating a sort of a utopia for the social determinants of health? And then what type of policy would you like to see anchored first in order to perpetuate it?
Well,
Small question.
I'm gonna answer this question, and when you ask me a year from now, I bet you my answer will be different, so I apologize for that. Just like when you would have asked me after Katrina, what's the most important thing we can do, and we asked ourselves that question, I said build primary care.
Yeah.
And I'm not sure if that was the right choice. Maybe we should have built sidewalks and focused on, the built environment, which is what Tom Farley wanted to do. But anyway, it seems to have worked out over the course of time. So, but here's the thing, because I've already shifted a little bit. When we started Public Health 3.0, I had a burning sense that I needed to use my federal bully pulpit, if you can call it that, and my resources to call attention to the fact that local governmental public health was starving to death, but it was the thing that you're counting on every day to save your life. And it doesn't have a voice, though it's very loud. And when we talk at the federal level to local public health, we think about and talk to the state government. And what I saw as a local health commissioner, as a local community member, and what I learned from these communities is that by the time money or resources trickle down to them, there's not much trickling. But when bad things happen, they're called upon to support and help people. And for lots of reasons, a really tenuous situation. And so this report talks a lot about how to strengthen local public health as the weakest link in the chain of all the folks trying to work on addressing health in this Public Health 3.0 era. I, over the course of the last year, have evolved in my thinking about this a little bit, and I'm not sure that, and you see this in the report, because we backed off some of the language, that it's not just that local governmental public health should be the chief health strategist, but there ought to be a chief health strategist. I'm going to use Bill Frist again as the example. It's such an unlikely character, at least in my mind, for someone who's a public health champion and advocate. But in Nashville, Bill stood up and said, as the community goes, we go. The right thing to do is to raise the mean and close the gap. It's not just about the rich doing better. And he rallied the business community, public health, and the healthcare sector around a table and got them focused on a future vision. They have a collective impact approach. They're sharing money, they're sharing resources, they're sharing data, and they're trying to make an advancement. And here's the sort of practical thing that caused me to change my mind. Two things. One, when you're drowning, like a lot of local public health officers and departments are, it's really hard to take on something new. And so it's a lot to put on them. But we are also really good in public health at knowing how to be at the table or follow when appropriate, and support. So we don't have to lead everything. And so it's okay if somebody else steps into the void, as long as we're there. And the second thing, though, is that I think fundamentally local public health has gotten itself into a bit of a pickle by not wanting to modernize. And I'm going to be really specific about this, and it has to do with something wonky, which is about jurisdiction. And so in New Orleans, I was the health commissioner for New Orleans, which is a parish / we call them parishes, a county, in the middle of a regional area that is seamless when you live there. You don't really notice the difference, especially if you visit, but also if you live there. People live, learn, work, and play all across the jurisdictional boundaries, but my reach was only in that area, and I had no counterparts in other areas because we had a centralized whatever. There are other places like Dallas, Houston, as examples, where they have multiple overlapping jurisdictions. And then there are places that touch and overlaps from suburbia, as an example, and then there are layers. What all this means is that there's a lack of clear accountability, a lack of clear voice for the community about who public health is, and it gets frankly frustrating and confusing for people writing checks, legislatures, governors, funders from foundation world. Why are there 2 or 3 people in the same geography?
Yeah.
So I think public health needs to do some serious work on that, and there's places that are, Kansas, Kentucky, Nebraska, Texas tried to think about it, but there's some, Ohio, there's some efforts that are happening, sometimes because they're being forced, sometimes because they're pulling it. But I think that it's more than just local governmental public health. And the last thing I would just say is it's the reason that the outside of the jurisdiction matters is because that's not how the local business community thinks, and they have to be engaged. It's not a policy thing. This is a private sector thing. I think that they really want to understand it and be engaged. And if I had to pick one policy thing today, which will hopefully be different next year, is that we would not take coverage away from people, because when you have that argument about coverage, like we have in this country for decades, it sucks all the policy oxygen out of the room. And you're talking about how much copay in primary care or whatever, what's an essential benefits package, and nobody has time to really talk about the stuff that affects health. And we're going to keep staying in that little tiny box, and people are going to keep dying, and it's going to keep costing more year over year.
Well, I would like to open this up because I think there's some really curious people in the audience as well. So please, those of you that want to ask a question, I think this issue of jurisdictions is of real interest to me. We have different regions for our EMS system. We have different regions for our transportation in the state. We have different regions for hospital service areas. And then we have the counties, of course, and others. And the monies are very different within all of those structures.
It really is. And I think, and we were talking at lunch about how siloed education and social services and public health are. And these local communities have found a way to blend leadership, or I said that twice, monies, data, and that's how they're more successful in working together. They've broken down those silos, but they tend to be temporary and based upon force of personality. One of the things I learned in Katrina, probably learned, but I guess before that, was that I'm a systems person. I said it like 10, you can have a mediocre doctor working in a really great system and they're going to perform better, or you can have a really great doctor working in a really terrible system and they perform worse. That's the healthcare framework. We forget to apply that to the rest of the world. And after Katrina, this whole idea of systems-based change, I got more and more bought into, including the leveraging of public health law. To give you a concrete example, though, to the primary care piece, I would go to these policy meetings, and there was the doctor's seat and the nurse's seat and academic seat and the insurance company's seat at these, around who was making decisions. There's no community health seat in Louisiana because we didn't have an organization. So I created an organization. I got my friends together and I said, well, we're a bunch of little ragtag clinics. What if we call ourselves 504 HealthNet and pop up a website and everybody pitch in $50 and we've got an organization? It was about like that. And as a result, then we had a seat at the table. There was a single voice. We learned to speak for each other and have a common platform. And that kind of structure, I believe, I guess I should say, those can then morph and do whatever it wants to do. And that's why I think that these kinds of models they're creating in Public Health 3.0 matter. That's why I think jurisdiction matters, because you build the foundation and then you can play on any field.
And
Please.
repeat the question.
Excuse me, sorry. You mentioned that.
When I say my friends, I meant all the clinic friends. I didn't mean just like my friends. I meant like all the leaders of the different clinics. And we had bylaws and we incorporated. It was a little more organized than that.
I guess my question is, you mentioned that a lot of the work you did was based off of relationships at first, and then you were trying to move it towards systems. And you also brought up collective impact models, which very much are based on relationships. So how exactly do you move from sort of crisis management or building something new that's so focused on leveraging relationships to actually building a system that outlasts all the people who have those relationships with each other?
So repeat what he said.
Oh, okay. So the question is how do you move from a relationship-based activity and success to one that's structural and sustained well beyond the individuals involved? And so I think that the organizational structure and sort of making sure that you have tables where people have trust. So governance is trust, and that there's you build a culture within that lives beyond the people who began it, and you do that very intentionally by the people that you bring together, by the rules and expectations that you set on building those alliances, and then how you hand off that information to people into the future. I think there's some really good models in that you may be familiar with, like the Federally Qualified Health Centers, some of their boards that do that well. But even that's focused on one sort of issue and challenge. So the structure matters. I think, and then I mentioned sort of succession planning. Succession planning begins on day one, and you have to start thinking about who can carry forward the work when you're gone. And that again means transparency, sharing power, sharing information, and bringing everybody to the table. I think that I'm still learning how to do that well, to be honest. And part of it is because part of that is the codifying it in policy and law. And this is my federal learnings that I'm having, and towards the end of my time federally, we were able to, I'll use IT as an example if I could. When I got there, the Congress sent me a letter and said, why is there an Office of the National Coordinator? Why do you even exist to bother us? And we think that we might kill you. And I'm paraphrasing just a little. And I was like, wow, this is a problem. Welcome to Washington. And fast forward over 3 years, they wrote into 21st Century Cures legislation more authorities for the Office of the National Coordinator. Republican Congress did that because we had learned from them, they had learned from us, we had worked with the community to help understand that we needed to modernize the office. It was working off of whatever, old authorities. And I think that gives me comfort going forward that some of the important consumer protections, for example, that we should be doing in the Office of the National Coordinator will stay because it's sort of codified in law.
And then Woody, and then Nate.
One of the things that makes Maryland unique in terms of these jurisdictional overlaps, it's one of the few states that has two primary public health infrastructures completely overlap, and they both overlap with the public health infrastructure of the state. I'm talking about the school system, I'm talking about Maryland Extension, and the county health departments. All have exactly the same boundaries. And it's one of the few states in which that actually exists. It seems to me that this is an opportunity, really, to get these working together in some unique ways. But I also wanted to thank you not only for your services at ASH, but also at ONC, and all that you brought to that. But my sense is that it's been a very, very long time since we've had support in HHS coordinated with education, that really believe what the Division of Adolescent and School Health has been saying for a very long time, and that is healthy kids are better learners, and that educated kids are healthier. And I'm surprised that we don't have a national cry for required coordinated school health programs nationally. And I know that education doesn't do that, but the states have to do that. But the thing that I find really unbelievable to me is the DASH was not just health education in the schools, but it was also dietary policy, environmental, and a whole host of, and physical education, and I just don't understand why there's not more support if we want to move upstream for required school health education, coordinated.
Talked about that today too. Let's see. I'm going to touch back a little bit on his question too, which is I think not just about forced personality, but about leadership, because it does matter. But leaders leaders tend to respond to where they have resources and where they have accountability that's very publicly displayed. And at the state and federal level, the resources for health leadership are in the healthcare, come from healthcare. So it's running Medicare, Medicaid, whether you're at the federal or state level, and it's dealing with that sort of regulatory apparatus. And so, as you can imagine, even if you're well-intentioned, the public health takes a back seat. The reasons I went to the Oval Office mostly were about delivery system reform and IT, to give out medals for Ebola, but it wasn't always, public health was only in a crisis of conversation. I think that's, I'm not casting aspersions on any of the particular leaders, but there's a reality to sort of how many hours you have in a day. And I think we have some work to do at the federal and state level to elevate the priority of public health. That's not just about a personal choice. That has to do with maybe something structural. And there's some discussion there's discussion about rethinking the way that we split apart health in the U.S. And I don't mean just federally, but at the state level. So pulling apart health and human services, and then now pulling Medicaid out, and creating additional silos and stepchildren sort of in that process. Forgiveness to the stepchildren, but it really just creates this unnecessary hierarchy. So some states are trying to bring it back together, and maybe that's the solution. I'm not sure. The financial things that states are looking at are to blend those funds. Block grants are a way that they think they might be able to do some of that work, but there are barriers to it. And I just want to make a very concrete example of how in the social determinants, one organization is trying to make sure that it's not just a nice idea to think about social determinants, but they're holding their leadership accountable. So in Trinity, which is a national healthcare company, their executives are accountable for not the health of the population that they serve in their healthcare system, but for the health of the community where their facility is located. So these sort of pay for outcomes payment models, which people are still thinking about, but this is really an executive performance outcome. So Rick Gilfillan, who used to run CMMI, is holding his executives accountable for smoking rates in the community, which drives those leaders to want to be at those tables with public health and others to really think about making change. And that's where I think you begin to change the prioritization of the conversations and how you spend your time. And it doesn't just have to be healthcare. Business could do something very similar.
Woody?
Karen, first, thanks so much for coming and sharing your thoughts and your insights. Several days ago, this country yet again experienced another national nightmare and tragedy. The news media doesn't amplify the issue that on average 90+ people lose their life every day in this country due to gun violence. Given your experience as a clinician, your the federal system, and in fact your personal experience in New Orleans with pure violence and thinking about this issue. Could you share with us some thoughts, some insights about how we move forward in developing a public health approach to the prevention of gun violence, like we successfully did with tobacco, automobile safety, and some others? So I would love your thoughts about, from your experience on the ground to your experience here in Washington, and with this yet again national tragedy. And again, I want to emphasize that unfortunately a few blocks from here, every life lost is a national tragedy, not just when it reaches larger than 4 that becomes quote mass shooting. But I would welcome your thoughts to share with us about how to apply public health approach.
When I became health commissioner in New Orleans, I took my little fancy self down the street and had my little set of priorities about what we were going to focus on based upon the epidemiology in our community, and it was cardiovascular disease and risk factors. And because we did a MAP process, a community health assessment and improvement plan, we were doing focus groups in community, and over and over and over again what they said to me was, our biggest health challenge is violence. Our biggest health challenge is violence and safety. And I just didn't see it from where I had been before. And I want to tell you that when I did these Public Health 3.0 listening sessions, we went to 5 communities around the country, had about 100 people come in that we invited. Violence always was at the top of the list for these, and I'm talking like, Kansas and North Bay and California. So it's a big issue for people on the ground, but it's not gotten the kind of scientific attention that it needs. The data that we were looking at as health commissioner about what to do, what is the evidence-based policies that we can enact, it's really limited for reasons that we probably know, that the CDC's not been allowed to do research. So I think public health needs to build an evidence base so we can know what works and what doesn't. And but we shouldn't wait for that. I think the other thing that we learned a lot in New Orleans was that illegal guns were our day-to-day big challenge, and that those are more tactical approaches than strategic approaches to dealing with illegal firearms. But that was what was killing most of the young men in our community. We also learned that tactical approaches to gun violence only get you so far. So doing the short-term arresting, you can't arrest your way out of the problem, is what we would say. That the complementary public health approach, which Cure Violence brings, is really about building an infrastructure to help combat the daily allostatic load stressors that these children and families are exposed to across generations. And that their reaction to stress and trauma and violence is probably perfectly expected based upon what's happened to them physiologically and sort of what environment, the environment in which they're living. And we were talking earlier about stuff that keeps me up at night, and this was always one of them. I didn't get sort of specific in this environment. I was talking a little bit more selfishly about my own experience of being moved from one zip code to another when I was growing up, and how I know that changed the trajectory of my life. But when we were in New Orleans trying to help these young men, because they're mostly young men, get out of a cycle of violence, they would always ask to be moved. You know that from your work. Like, well, I got nowhere safe to go, and was sort of moving them from one zip code to another. And so I just want to acknowledge that even in that granular space, you feel pretty helpless a lot as a health commissioner. So it on the daily basis, it's pretty difficult to do. But we need a lot more evidence-based policy, and I think we need to be more. I think we need to be serious about the fact that there have to be a few more stops in the chain about how we're doing a check on whether somebody's ready and able to have a firearm. I'm from the South. We have guns. I hunt. I get it, but it's also, like you say, a daily stress and violence thing that we take for granted. And I want to just say this in a way that will probably not be as articulate as I want it to be, but one of the things that I learned as when I was health commissioner was about this really horrible fact that's more in the the national consciousness now that when a black young man dies, it's not a national tragedy, and they're literally dying every day. And it was Mitch Landrieu, the mayor of New Orleans, who made this for us, not, oh, some kid died. He had a binder of every kid that was killed, anybody that was killed, not just the kids. And he would get a picture of them as a child and a picture of them at the murder scene, and have that, and have a bio on them. He would talk to their family, so they were all real people to him. And I think if we could begin to put that in our minds, that these are not statistics, these are real humans, and they deserve better by us, we might do better. Last thing I'll say, this is a long game. And that's the problem in the political sphere, is that we want a quick answer. Early childhood education done well takes years to show good impact. And so this is just policy and cultural. We need to recognize we're going to do more, but do more longer. Last question. Okay.
Neil, and then I think we're going to close. You're going to
Perhaps less timely a question, but I was struck with something you said about public health in the policy arena, and that it's reactive, which is sort of antithetical to our field. I think about when I define public health for my students, it's upstream when done well. It's something that isn't necessarily noticed at all. And because I'm a technologist, I have a technology question related to this and about your time at ONC. I always found it neat that you were sort of a confederate for us in public health when you were there. And I want to know what your thoughts are about the role of public health shaping the conversation and action around health information technology. When right now, like issues like interoperability are seen as like clinical problems, when in reality, if solved, community organizations would benefit from better access to health information technology.
Okay, I worry about silly things too, not just big societal problems. And one of the things, and I don't know if this isn't actually silly, because this is one of the things I worry about. I get asked sometimes sort of, what is the new administration doing that has you concerned? And I see a few signals in my legacy at the Office of National Coordinator that I don't want to get lost. And So first of all, to say something about public health, and I'll get back to the federal thing. Public health is learning to work with unusual data sources, and learning that perfect can be the enemy of the good, and that timeliness and granularity can be of great benefit to a community or population level intervention, and provide a feedback loop that keeps not only elected leadership and public health energized, but the members of a coalition energized. And so whether you're looking at using retail data or bike share or social media data, did you see this paper that just came out in American Journal of Public Health where they used tweet data from across the country and showed that it correlated with things like alcohol consumption and physical activity, just from people who were tweeting, which is like me and Boris, but apparently we're indicative of the community. So there's new ways that public health is trying to open its mind about how it can use data and give more timely information, so we're not waiting 3 years to know that people are dying from an opioid overdose, right? Overdoses across the country. And I'm glad for that, but we have a lot of work to do. The federal piece, though, is pretty important, and I tell you this more as some, so we had this idea that it's not about the electronic health record, it's about the data and the information it conveys, that there are a lot of use cases for it, public health being very important. So there should be a lot of on and off ramps. There should be lots of ways data moves in and out of the system and can be aggregated to be put to good use. And that the public paid a lot of money for those electronic health record systems, and so the public ought to gain from it. And models like Macroscope in New York, or what they're doing in Massachusetts, are great examples of how the electronic health record data is being put to good use for surveillance and helping public health. But that was in a world in which we were pushing openness of data liquidity, and APIs, doorways to the data. And there's some rhetoric in the Office of National Coordinator and across HHS that's moving away from that and thinking about it having healthcare use. And if you're interested, if you think that it should have more use cases than just that, then you should write letters, and you should make that known when RFIs go out or when they ask for interoperability outcome measures, because otherwise that voice will get lost in spite of there being good people in there. And it's so critically important. And I'll tell you who it's important, not just to us in public health, but venture capital, the business community, all these public health 3.0 communities need and want this data to be, and just as consumers do, to be able to tell a better story. So a lot of constituencies, they just don't have as loud of a voice. So yeah, keep focusing on that and make sure that we don't lose ground. Done. Elaine's giving us the hook.
Well, it's appropriate, I think, right, that we're ending with a discussion about data. Thank you all. Thank you, Karen, so much for being with us. You've given us lots of things to think about. Thank you for all of your questions and for your attendance. But importantly, now, please join us. We're going to have a reception right out here, outside the doors, and there'll be the opportunity to talk more directly with Dr. DeSalvo. So thank you so much, Karen.